Examining a child with suspicion of a supracondylar injury. When examining a child with a suspected supracondylar injury, it is exceptionally important to work out if there is any neurovascular injury, as this will directly influence your course of management. The different management strategies will be discussed a little bit later in the tutorial. Physical examination. First, you want to inspect the limb. Is there any clear deformity, gross swelling, or any bruising overlying the anterior portion of the elbow? A child with an elbow fracture will usually refuse to move the elbow, and it is not advisable to start poking and prodding the elbow of a child with the high suspicion of this injury. This is unlikely to provide any further information and will distress the child. Neurological examination. The most important part of the examination is the neurovascular assessment. This must be done before any treatment is performed, as it is important to make sure that any treatment pursued has not itself caused a neurovascular injury. First, you want to check the sensory area supplied by the three main nerves and attempt to get some information on if the child can feel you touching them. This might be challenging with a child who is very young, but you must do your best and document your findings. Firstly, touch the first web space on the back of the hand to check the sensory distribution of the radial nerve. Gently touch the tip of the index finger to check the median nerve. This is the most important, as this is at greatest risk of injury with a supracondylar fracture. And then finally, touch the tip of the little finger to check the ulnar nerve. Next, you want to check the motor supply from the three main nerves. It is best to ask a child to copy 3 simple hand gestures, as any verbal instruction will likely prove futile. First, ask the child to cross their fingers. This assesses the ulnar nerve, which supplies the intrinsic hand muscles. Next, ask the child to give you a thumbs up. This assesses the radial nerve via its action on the muscle extensor pollicis longus as it acts to extend the thumb. And lastly, but most importantly, we need to check the median nerve, and more specifically its motor branch, the anterior interosseous nerve. Ask the child to make an OK sign. This is making sure the tip of the thumb and the tip of the index finger are clearly flexed. This is demonstrating the anterior interosseous nervous supply to the flexor pollicis longus, which flexes the tip of the thumb, and flexor digitorum profundus, which partly acts to flex the tip of the index finger. If there is damage, the child will be unable to make an OK sign, and both fingers will touch held in extension. Vascular examination. First, feel the hand. Is it warm? Is it pink? Does it appear well perfused, or is there a concern of poor perfusion? Is the hand cold? Is it pale? It is important to assess the presence of a radial pulse. It is then important to assess capillary refill. You must ensure that pulses are present and capillary refill time is no longer than 2 seconds. If either are absent, this could indicate an injury to the brachial artery.